So for this next skill, we're going to be working through the head-to-toe assessment. This is going to be following the acronym DCAP BTLS. So that stands for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. So going through that deformities, anytime when we're palpating and a bone or a portion of the body is deformed, it's not the correct position. DCAP, C, contusions. We're looking for that ecchymosis, any bruising, contusions, or that hematoma as well. Abrasions, any scrapes. Punctures, any holes. Burns, we're looking for that on the skin. Tenderness, we're really looking for their face. So as we're doing that abdominal palpation, ooh, do we see any grimacing? Anytime that our patient shows that an area is tender. Lacerations, any cuts. And then that last one, S, any swelling. Anytime that we observe swelling in an area. We're going to be following through every single bone in the body, going from the head, the most important part, down to the neck, the torso, the abdomen, the legs, which are going to be a lot bigger than the arms. So we want to go to the legs first. And then lastly, followed by the arms. The final thing that we're going to do is we're going to roll their patient on our side, and we're going to then palpate through the cervical or the thoracic, lumbar, sacral spine, look at the buttocks for any defecation, urination, and then the legs for any visual abnormalities. After this, if we've decided that this is a spinal patient, we can then roll back onto a spinal board and complete the spinal immobilization skill as well. And we would have already gotten the PMS, the pulse, motor, and sensory, both the arms and the legs, so all 4 distal ends of the body. So let's go ahead and let's start looking at what that sounds like. So for the head-to-toe skill, we're going to start with the head and we're going to palpate everything all the way down to the toes. We're going to make sure to feel every single piece of the body, but also to be going through the acronym DCAP BTLS. So again, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. So we're looking for all of those components throughout your palpation. So we're going to start up at the head. We're going to start with the frontal bone. And we're going to feel down to the parietal bone, around to the occipital bone underneath the head, forward to the temporal bone, through the zygoma, up to these nasal bones, down to the maxilla, and around to the mandible. When we're feeling these bones, we're making sure to be looking for ridges. So on the skull especially, if we have a compression fracture, we're going to feel a ridge as we palpate. We're going to feel an edge. That's what we're looking for. So if we just palpate by touching and moving, we're not going to find those markers. We're not going to be looking as a detective. We're going to be looking for anything we can find. So sliding along here is going to be the best option. Once we've gone from the frontal, parietal, occipital, temporal, we're going to go to the zygoma. Now we're doing the facial bone. So zygoma up to that nasal bone, through the maxilla, and then down to the mandible all the way around. So now we've felt all of these bones. We're going to grab out our pen light, and we're going to start investigating as well. We're going to look at the eyes. We're going to see if they're pearl. All right, pupils are equal, round, responsive to light. She's right now at about 5 or 6 millimeters. I'm going to look into the nose, so I'm looking in the nares. I'm looking for any cerebral spinal fluid, any blood. Again, with that chapter 25 bleeding, we saw that if we took a piece of gauze and just dip it into any blood, we'll see that CSF kind of pulling out, forming that halo. In the mouth, we're going to go ahead and lower down the mandible. And we're looking in for any foreign objects, any blood, any teeth, or anything that we might have to suction out. So now we're going to look around at the ears. So we're looking inside the ears on both sides. But we're also looking for blood pooling up at the mastoid process. These are called battle signs. So we're looking for any battle signs through here. This would be indicative of a basilar skull fracture where something is bleeding and it's draining down and pooling right around to the mastoid process through here. Additionally, when we're looking through the eyes, we're looking for any dehydration, any of that conjunctivitis, or anything that is abnormal throughout the face and all those sensory organs. So now we're going to work on the neck. So we're going to palpate through the cervical spine. We're going to be looking around for these jugular veins to be distended, and we're going to feel that the trachea is indeed midline. Some other things that we're going to be looking for is we're going to be looking for any medallions or any medical ID. So if there was a medical ID necklace that said that this patient is a diabetic or that has a seizure disorder, then we could think, oh, maybe they are hypoglycemic. Maybe they're in that post-ictal phase through here. We're going to continue down to the chest. We're going to start with those shoulders. We're going to continue through the clavicles, down this sternum, straight through the center, and we're going to extend out through the coastal arch, through the xiphoid process, and we're going to give a little bit of just a hug through here, just pressing, just to see the stability of this rib cage. From there, we're going to go ahead and palpate up through the soft tissue, making sure to use the backs of our hands. Again, this is a lot more clinical than the fronts of our hands. So we're going to use the backs of our hands, and we're just looking for any flail chest or any disturbance in that soft tissue through there. At this point, we're going to go ahead and grab our stethoscope, and we're going to auscultate. We're going to auscultate again the tops, checking bilaterally in the center, and then this lower area of the lungs, checking bilaterally. For this, we're looking for any lung sounds, any absent lung sounds, to make sure that our patient isn't experiencing a pneumothorax. We're also looking for any rales, any crackles, to see if the patient is having any fluid in the lungs, or any wheezing or stridor for any obstructions. From there, we're going to move down to the abdomen. So I'm going to go ahead and lower my patient's hands to their side. If they're having pain, we're going to start from the adjacent quadrant. If they're not, we're just going to start anywhere. And we're going to just roll through. And we're looking for, again, that acronym of TURD. We're looking for a tenderness, so I'm looking at my patient's face. I'm seeing if she reacts in pain. I'm also looking for any guarding that I'm seeing, so that subconscious flexation of the muscles. I'm looking for rigidity and distension in what I'm feeling. So if any of the organs underneath are distended, if they're rigid, I'm going to feel those edges. On a normal patient, I'm not going to feel that much. I'm just going to kind of feel a gentle squish all the way through. But let's say that my patient's liver on that upper right-hand quadrant is distended. We have some cirrhosis of the liver. I'm going to actually feel the liver and feel the line of where it ends, that edge where the liver ends. That's what I'm looking for in the abdomen. Again, we're going to go clockwise, starting in the square adjacent to wherever the pain is, or just kind of wherever you want to start. Moving down to the pelvis, we're going to push down on the pelvis, and then in on the pelvis. If we see a pelvic injury, an obvious pelvic injury, we're not going to do this. We're not going to palpate the pelvis. Again, we're looking for injuries, not confirming them. But if I don't see an injury, I'm going to put about 10 pounds of force down and in. I'm just trying to see if the pelvis is stable. Some teachers tell you to give a nice little rock of the pelvis, which would not be beneficial if this patient had a spinal injury. So make sure to put even pressure down and even pressure in so that we do not upset that spine in case of an injury. From there, we're going to move down. We're going to look in that genital area. So for a man, we're looking for priapism, that uncontrolled erection due to neurological trauma. For a woman, we're going to look for any vaginal bleeding. For both patients, we're going to look at that perineum in between the anus and the vagina, or the anus and the scrotum. We're looking for any trauma there, any lacerations, or any bleeding due to trauma or something else. For both these patients, we're also going to inspect for any urination or defecation to see if there's anything wrong with their bladder or that sphincter control if they voided themselves. We're now going to move down to the femurs. So for any long bone, how we're going to palpate it is not with both of our hands together. Again, we're looking for breaks. We're looking for that false motion where the bone should be steady, it should be straight, but there's some motion in the middle of the bone. That's what false motion is. So if I grab like this, I'm not going to feel it. If I grab just with my hands a little bit extended to either side, that's how I'm going to feel that false motion. So that's how I want to palpate all of my long bones through here. So I'm going to go ahead and start. I'm palpating through here. I don't feel anything. We're going through here. For the patella, we're just going to give it a quick little wiggle back and forth. We're just going to go to right, left, and we're going to make sure that that has a nice little wiggle going on either way. Again, I'm not going to be able to find any specific damage, but I'm going to just make sure that those tendons are in the right place and that that kneecap is sitting on top and hasn't been progressed to one side or the other. Moving down to the lower leg, that tib-fib area, I'm just going to be palpating again using opposing pressures. And then I'm going to get down to the feet area. I'm going to go ahead and remove the shoes without moving the spine. And I'm going to palpate down through the heels, through the tarsals, metatarsals, and phalanges. Again, the calcaneus, tarsals, metatarsals, and phalanges. A lot of EMS instructors will tell their students, all right, go ahead and pedals to the metal, move your feet like you are moving a car to try to get that PMS, that motor. I don't like that because if they do that, go ahead and do that for me. As they are moving their feet, they are moving the rest of their body too. And if they had a spinal injury, I just don't want to risk that. So instead, I'm going to ask them, hey, can you wiggle your toes for me? Awesome. So she's wiggling them bilaterally. That muscle is also a little bit further distal than the ones to move your ankle as well. I'm going to check for a pulse. So I'm going to try to find that dorsal pedalis. That's why we spent so much time in class finding it. Ooh, you have a strong one. So I feel them right here, and I feel them bilaterally equal. So I feel them with an equal strength on both sides. If my patient had a swollen knee, and on the left side, I was feeling a diminished pulse, diminished strength, I might be able to be scared that that swelling is causing that blood supply to be cut off just a little bit. If I'm trying to find it, I can't find it, I'm going to try that the posterior tibial pulse. If I can't find that, I'm just going to go straight into a cap refill, looking to make sure that I see that under 2 seconds for all patient populations. Once I've gotten there, I've now done pulse, motor. I still need sensory. Hey, ma'am, can you tell me what toe I'm touching?
My left big toe.
All right, what about now?
My right pinky toe.
Perfect. So now I know PMS is intact. So she has a pulse going to both extremities. It's equal bilateral. Her motor sensation, those efferent neurons work, and then those afferent neurons as well work with the sensory getting back up to her brain. I've now gone head to toe all through that top of her body, but I've forgotten her hands. I haven't done her hands. Again, we're going for the most important pieces of her body first. So that head is that most important piece. The chest, the abdomen is most important next. The legs are going to be more important than the arms just because they're bigger. They have more blood supply going to them. So now I'm at the arms. And we've already done the shoulders, so I'm going to go ahead and palpate down the arms. Feel for that olecranon process, that ulnar process, down to the carpals, metacarpals, and phalanges. On this side too, I'm feeling that humerus, radius ulna, that olecranon back here. The wrist bones, those carpals, metacarpals, and then phalanges. At this point, I still need to do PMS. So I've gotten to the end of that distal extremity. So I'm going to feel my pulses equal bilateral. And they are indeed equal. All right, I'm going to go ahead and say, all right, can you squeeze my hand? All right, squeeze, 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 squeeze. Awesome. What finger am I touching?
My thumb.
Which hand?
Right.
All right, now?
My left pointer.
Awesome, perfect. So I've now assessed that PMS. For the motor, I've done something a little bit different. I've asked her to squeeze and hold on that. I'm also testing kind of that neurological deficit, so kind of in that fast scale, looking for a stroke that she can hold and that she's not having any diminished muscle strength or sided weakness through there. So I'm asking her to hold for a couple seconds and really, really squeeze. And that's not going to hurt my finger because she can't squeeze that tightly. No patient can. I've now done head to toe and those arms, and I've covered everything on that ventral side of my patient. So now it's time to check the posterior, to check the back, the lumbar and spine. So whoever is on the head, whoever has been holding my head stabilization, my cervical stabilization, they're going to count for me. I'm going to get another person to help me roll. We're going to grab, and on the heads count, ready, 1, 2, 3, we're just pulling, doing that log roll up. So I, as the primary, I'm going to take my hand, my lower hand, and then I'm going to start at that. I've already done the cervical spine, so I can move down to the thoracic spine. I'm just checking that those vertebral bodies are all in line. Now we're at the lumbar. We're at the sacral and the coccyx. I'm going to go ahead and examine the buttocks for any bleeding, any urination or defecation, or really anything wrong with this. So any scrapes, anything that shouldn't be there, any contusions, that full decap BTLS. I'm still looking down for the lower legs with that posterior portion. And I'm looking again for anything else that I can see. I don't see it. So then we're going to go ahead and move on to that spinal immobilization skill, which we're not going to do today, but we're going to put that spinal board in at her back on the heads count. Ready, 1, 2, 3. We're going to lower it back down. We're going to center her on the board using that V maneuver, and then we're going to go ahead and immobilize her with straps, making sure we get the shoulders, the torso, the hips before we start the head at all. At that point, we're done with the head to toe. We can load on the ambulance, start our vitals, sample, start reassessing, and then get her to the hospital and finish that skill. Go ahead and practice this a couple times. Now that we've practiced that head to toe skill and we're a master at going through and feeling and palpating every part of the body, we want to try to integrate that into our patient assessment. So this is going to be a secondary assessment for any trauma patient where we don't know what all the traumas are. So if I got beaten by a baseball bat and I can tell you, yep, they hit me once and it was right here, I don't need to do a head to toe assessment because I know where all the trauma is. I know where all the damage is. But let's say that it was, in this case, I got beaten multiple times and I wasn't able to tell you exactly where I was hurting. Now we would have to do that head to toe, trying to find where all the trauma is. Additionally, if anyone is altered, if they're unconscious, or if they are not able to tell you where all the pain is. We're going to do that head-to-toe assessment, mostly just to find anything that there's there. If they have that fracture to the tibia and fibia, we wouldn't know if they're unconscious. We wouldn't know unless we feel it and we can find, oh yeah, I can feel it there, and that's when we're palpating the legs with the alternating hands. So what we're going to do is we're going to integrate this into our trauma assessment. So this is that National Registry skill. This is the patient assessment trauma. So we're going to treat this just like any patient assessment, always starting BSI, scene safety. What is my environment like? What is my number of patients? 1, 2, 3. If it's 3, we're going to have to get another ambulance. Additional resources, that could be that additional ambulance. It could be ALS if we have an ALS procedure that we need to do that we cannot do as BLS providers. E-names. M, mechanism of injury versus nature of illness. I'm going to choose that mechanism of injury because it's going to be that trauma. And then we're going to try to figure out, okay, what types of injuries it is. Extrication. How are we going to move them from wherever they are to the back of our ambulance? Are we going to consider using a long backboard? Can we get our wheeled stretcher in? Are we going to have to use a stair chair? Or what does that look like? And then the last one, spinal precautions. If this is a trauma where we're considering spinal, we're going to direct our partner, our secondary partner, could you go ahead and maintain spinal precautions? And that's where that happens there. We're going to now enter into that primary assessment, starting with the general impression. What do they look like? Our level of consciousness. Now, for a trauma patient, that usually we won't go into the PPTE, the person, place, time, and event, to determine orientation. We'll just determine an AVFib. Okay, they're alert. Let's move on now to the chief complaint or apparent life threat. So if they're unconscious, that's their chief complaint, is that altered level of consciousness. But if they're able to verbalize the chief complaint, then we're going to take whatever that is. With those apparent life threats, we're looking for exsanguination. If they're bleeding out, we're looking for any severe burns. We're looking for if they have a pulse and they are breathing. And if they don't have a pulse and are not breathing, instead of the ABCs, we go into that CAB sequence, this compressions airway breathing that the American Heart Association publishes. For the purpose of this exercise, they have a pulse, they are breathing. So now we're going to move into those ABCs. So airway, open, clear, maintained. Is it open, head, tilt, chin lift? Is it clear? We're going to think about suctioning. And then is it maintained? We have to mention that we're going to consider putting an adjunct in, whether that's an oral pharyngeal airway or that nasal pharyngeal airway. From then, we're going to move on to breathing. First off, are they breathing? Well, we've already determined in the apparent life threats they are breathing. So then we can move on. Is it adequate? For adequacy, we're looking at the rate, rhythm, quality. How fast are they breathing? How deep is that breath? And then is it a regular rhythm, or are we showing signs and symptoms of maybe that Cheyenne-Stokes breathing, periods of apnea followed by periods of tachypnea with the deep breaths, and then reverting back to apnea? Are we showing ataxic or biot respirations as well, or those Kussmaul? So we're trying to figure out if this is an adequate breath, if this is a real breath, or if we're going to need to assist that with the bag valve mask, with that positive pressure ventilations. The final thing that we're going to be considering in the oxygen area, in the breathing area, is does our patient need oxygen? Are we going to prescribe them oxygen via nasal cannula, non-rebreather, or through that bag valve mask? And that's when we would apply it there. Additionally, for trauma, we're going to look at one more thing. We're going to look at any injuries that could compromise the airway and breathing. So I call that exposing and treating. So we're going to look through the chest. Do we see anything through here? Do we see any holes? Do we see any sucking chest wounds with that pneumothorax that it might create? Or anything in there? For the purpose of this exercise, we don't. So we're going to move on to circulation. There are 4 things that we need to check. First off, how is their pulse? We already know that they have a pulse and there's apparent life threats. But then how is it? All right, rate, rhythm, quality. Is it fast? Is it slow? Is it strong? Is it weak? Is it regular cadence or is it irregular? We're then going to look for any bleeding. So maybe we're going to do a blood swap where we're just going to kind of touch everything with our gloves and then look at them. Do we have any blood on our hands? That's that blood sweep where we're just looking for bleeding if we can't see it. So for those skin signs, we're going to look at temperature, color, and condition. So for temperature, are they warm? Are they cool? For color, are they pink? Or are they maybe cyanotic or ashen gray? And then for condition, are they diaphoretic? Are they sweaty? Or are they dry? Now we can make our final decision. Are they going into shock or are they not? That's that 4th thing for circulation. Shock or not. Do we treat with POUT or do we not? With positioning, oxygen, warmth, transport, or can we move on? After the ABCs, we're going to move on to the next letter of the alphabet, that D, our decision. Are we going to stay and play? Is this something that we feel confident that we can treat on scene? Or is there not a problem with the ABCs? Or is there a problem with the ABCs where they're having altered level of consciousness? They're breathing erratically. They can't maintain their airway, or that their pulse is weak, is too fast, or they're going into shock. If there's a problem with the airway, we're going to go into that decision, decide to drive. The problem with breathing or circulation, again, decide to drive. And we're going to use the GCS, or Glasgow Coma Scale, to determine that transport as well. So with GCS, we're looking at the first category, eye opening. It's going to be AVFU. Are our eyes open and alert? Are they only open to verbal stimuli but then go back closed? Are they only open to painful stimuli but then go back closed? Or do they stay closed the entire time? 4 points, 3 points, 2 points, 1 point. Our next is our verbal orientation. Are they oriented? Hello, how are you doing? Very well, thanks. Actually, I'm not doing so well because an EMT is helping me. Are they confused? I'm not sure what's going on. So that would be that 4 points. So 5 points, 4 points. The third point would be inappropriate words. Hey, are you okay? Chicken, crab. So something in that problem with associating words, inappropriate words through there. The last 2 points and 1 point are going to be either sounds, or so incomprehensible words, or for that 1 point is no verbal response at all. So again, verbal, it goes up to 5 points. Oriented, confused, inappropriate, sounds, or no verbal response at all. Now we can move into motor response. So our motor is going to have 6 points through there, giving us a total of 15 points. The 6th point would be oriented and able to follow commands. Hey, can you shut your head? Awesome, cool, I can do that. Second one is going to be able to localize pain. So maybe they're unconscious, but they're holding their olecranon, and they're focusing their attentions there. And then the next one is going to be that they are responding to pain. They are retracting from pain. So if we give them a trap squeeze, maybe they're pulling away normally. If we stimulate a muscle, they're pulling away. The next two are very similar. It's going to be decorticate, so abnormal flexation or decerber, so abnormal extension, leading us to that final 1 point, which is no muscle tone. So they are limp. They're not responsive. If we get a GCS of 15 or 14, we're going to be comfortable. But if it's that 13 and below, we're going to make that decision to drive. So load and go. We've now finished our primary assessment, so now we can move on to that head to toe. So on your National Registry skill sheet, it says taking vitals and doing a sample history before you do the head to toe. Here's how I would like to address that. If this is a stay and play, go ahead and take sample. Go ahead and get some vitals. If this is a load and go though, we need to go. We can take sample, we can take vitals in the back of the ambulance. So let's go ahead and load them into the ambulance first. But before we can load them onto that backboard, we need to do the head to toe. Before we can load them onto the stretcher, we need to load them onto the backboard. So I would prefer if you go ahead and do that head to toe, load them onto the backboard, onto the stretcher, start going, and then circle back for those vitals and the sample. However, if you had multiple personnel, which is likely for a trauma, you could designate one member of your crew to get a set of vitals, and then another member to maybe interview family to get that history, and then you yourself could work on that head to toe and getting them onto the backboard or onto your stretcher. For the purposes of our National Registry skill testing, we're going to go ahead and we're going to do the head to toe first. So that's the skill that we just practiced. So we're going to start looking at the frontal bone, parietal, occipital, temporal. We're going to look through the face, so with those nasal bones, the zygomatic bones, the maxilla, the mandible. We're going to look in the eyes, nose, mouth, ears. We're looking for CSF, blood, any foreign body objects, really anything that's abnormal. Additionally, for the eyes, we're looking to see that they are pearl. We're now going to move down to the neck. We're going to look at the trachea that's midline. Jugular veins aren't distended. We're going to feel that cervical spine, and we're going to look for any jewelry through here, any medical alert bracelets. I don't care if they're wearing a diamond and a pearl necklace, but I'm concerned if they have a necklace that says, hey, I'm diabetic. Because then we know, oh, maybe they're unconscious because they're in a hypoglycemic state. After that, we're going to go ahead and we're going to test this thoracic cage. I start at the shoulders, move in along the clavicles, down the sternum, around to the ribs, give it a little bit of a squeeze, move up on this side. I now take my hands on reverse, and I go through the soft tissue, and then I oscillate. We're going to oscillate at least 6 areas in the chest. From then, we can move down to the abdomen. We're going to palpate. It doesn't matter what quadrant unless there's pain, unless your patient is saying, I have pain in this quadrant. And then we're just going to go through in a circular motion, ending with that painful area. For the palpation, especially for the conscious patient, you want to be looking at the patient's face. You're not going to get any cool insights from looking at your hands, so you want to look up at their face. Do they react? And then for feeling, you want to look for guarding. And again, we're using that TURD acronym. So tenderness, rigidity, and distension for palpating in the abdomen. So tenderness, does it hurt? We're looking at their faces. Rigidity, is there anything rigid in there? And distension, is there anything that's pushing out? Or even with pain, is it painful on the pushing in or painful on the pulling out? Does it be relieved with the push in and then hurt more on that out? We're now going to move down to the pelvis. So we're going to push in, and we're going to push, down, and then in. Again, we are not going to rock the patient, especially if we're considering a spinal injury. From there, we're going to move down to the genitalia. Now, in this area, we're looking on men for priapism, on women for vaginal bleeding, for anyone really bleeding an injury to the perineum or to the anus or anything in there. Also, we're looking for defecation and urination. So seeing if we're thinking about maybe a cholinergic, a nerve agent, or something like that, where they're defecating or urinating or voiding their bladder by themselves without control. From there, we're going to move on to those femurs, and we're going to use an offset hands to palpate. Again, if I palpate just with my hands like this and it's broken, I'm not going to feel anything. I'm not going to feel any of that false motion. So I'm going to palpate with offset hands. Make sure to wiggle that kneecap back and forward and go all the way down tib fib to the feet. Once we get down to the feet, we got to the end of a limb, so we need to take PMS, pulse, feeling for that dorsolateral pulse or the posterior tibial pulse. If we don't feel that, we're in 10 seconds, then we're going to take a cap refill. We're always checking bilaterally. So does this foot have the same pulse strength as this foot? If not, there could be an injury. So checking bilaterally. Once we've done PMS, so also that motor and sensory, then we're going to move back to the arms. A note about motor. A lot of instructors will say, all right, put it on the gas pedals, push on the gas pedals. And so you're moving the foot like this. That moves the entire body just a little bit, and that's controlling the muscles up in this kind of leg region. If you ask them instead to wiggle their toes, it's not going to move their back, and it's controlling muscles a little bit further down. So I would much rather you prefer wiggling toes than moving like gas pedals, those feet. We're now on the arms, same deal through here. We've already palpated those shoulders. So we're going to start with the humerus, come down in those offset hands, palpate that olecranon, the ulna and radius, and into those carpals, metacarpals, and phalanges. At the end, we've now reached the end of an extremity, so we're going to check the pulse bilaterally, checking for even strength. We're going to check the squeezing through here, making sure that's an equal strength as well. That was motor, efferent neurons. And then the sensation. What finger am I touching? Cool, the pinky, the thumb, the right thumb, left pinky. Awesome, cool. We've now done everything on the front half, so we're going to go ahead and we're going to turn our patient over to the side. We're using that barrel roll on the head's count. And then we're going to feel through, so the thoracic vertebra, the lumbar vertebra, the sacral vertebra. We're going to look again at the buttocks for any bruising, any lacerations, tenderness, swelling, the decap BTLS, but also for defecation and urination that we maybe could not have seen from the ventral side. We're then going to inspect the lower legs, the back side of the lower legs, and then once we're satisfied, we're going to roll our patient back onto that long spine board, or if it's not a spinal injury, then we can go ahead and move onto a stair chair, onto a wheeled stretcher, or however else we're going to extract that patient. So that's our head to toe. So we've gone head to toe. We're now on that backboard, the long backboard in our ambulance, and now we can get the set of vitals, and we can go into that sample history. We're doing signs and symptoms, allergies, medications, past pertinent medical history, the last intake and outtake, and then those events leading up to the circumstances, what they were doing before they had this accident. After that, it'll be about time to reassess our patient. So we're going back to the primary assessment, making sure that their level of consciousness is the same, airway, breathing, and circulation is fine, and then retaking another set of vitals. For a critical patient, we want to take that every 5 minutes. And for a trauma patient, that really is going to be most of the time, that we'll be reassessing every 5 minutes, every 3 to 5 minutes. If they happen to be stable, though, if we didn't find anything on the head to toe, they had a GCS of 15, ABCs were totally fine, then we could extend that to a 15 minutes. However, we are considering for shock, especially that psychogenic shock, and that they were up in that compensated area, and that now they might crash and go into that decompensated shock. That's it. That's this entire trauma assessment. That's everything on this National Registry skill sheet. So make sure that you're familiar with that head to toe, but especially how to integrate the head to toe assessment into this skill sheet. So then once we come back, we can really just knock this skill sheet out and go through first those BSI safety, E-names, primary assessment, secondary assessment, and then reassessment, and really get all those points down here, all 42. All right, guys. I hope you enjoyed this. Thank you so much.